And so that's the paradox of transfusion as we see it, as you see it. Blood is critical. I cannot do what I do every day. The surgeons can't do what they do without your help. And yet, in fact, we know that blood can, again, it can alter, transfused blood alters hypoxic vasodilatory responses, alters vascular perfusion responses at the capillary level. And so we know that, in fact, many of the reasons we give blood, that is to increase oxygen delivery to tissues, may in fact be the opposite of what occurs. It's risky to our patients, to our institutions, and I don't know what numbers you go by, but I think anywhere from probably 33 to up to 50% of our transfusions could be considered either inappropriate or perhaps unnecessary. It's also very costly to our enterprise. Mayo Clinic last year spent $150 million on total transfusion-related expenses at the Rochester, Jacksonville, and Arizona sites. $150 million. That becomes a real drain on institutional finances. 3 years ago, we started a fairly aggressive program using laboratory-guided algorithms for operating room and ICU transfusion. And in essence, we said if there's excessive bleeding in the operating room, order laboratory tests. And then based on the results of those laboratory tests, we developed some cut points that allowed us to then, based on these results and these cut points, either initiate a platelet transfusion or not, likewise initiate FFP or not, or cryoprecipitate. Or certainly if all the lab results were lower or did not cross that threshold, we then would take the patient to have the surgeon look again in the chest for bleeding. In the intensive care unit, our algorithm was somewhat similar in structure. Basically, if you have excessive bleeding, we're going to go ahead and get some lab tests, and then based on those results, and these cut points are somewhat different, but basically based on these cut points, we're then going to determine in an objective fashion whether or not we're going to transfuse, or if we don't meet these cut points, we need to go back to the operating room for re-exploration. So that's what we did, and here's what the results looked like. If we take a look on this graph, on this y-axis, percentage of patients transfused who had heart surgery at Mayo Clinic, and these are the red cells, plasma, platelets, and cryoprecipitate from 2008 down to 2011. So you can see a stepwise improvement, significant reductions in the percentage of patients transfused in red cells, plasma, platelets, and cryoprecipitate. Likewise, if we look at the annual number of units transfused for the 3,000 patients having heart surgery at our institution, you can see here again units transfused on this axis and again the various components. Again, a continuous stepwise reduction in the number of units transfused for all of our procedures over the course of these 4 years. What's also important to note that this is at the same time where we've had an increase in the number of procedures and a significant increase in acuity and complexity of patients. And so this is all the result of hundreds of clinicians working every day trying to take the best care possible of these patients having heart surgery. For the institution, cost of transfusion. So this is the total cost of transfusion in millions of dollars here. Again, the same components and the same timeline, and you can see a continuous reduction in total cost expenditures for transfusion associated with cardiac surgery. So I told you what we did. We implemented the transfusion algorithms. These are the results, and of course we're very pleased with the results. They're better than we ever anticipated, and again it's because we had hundreds of clinicians working together from the supply side and the demand side to help for the benefit of our patients. I would also tell you that we also reduced acute kidney injury in these patients during this course, so we reduced transfusion by 50% and reduced kidney injury, as well as we think perhaps reduced wound infection.